So we're just going to do a quick follow-up on a talk we did a couple months ago on the CRRT. I believe we had some technical difficulties as far as the second half of the filming on the actual setup and all. Just a real quick recap on the CRRT. This is the next stage version of the CRRT. There is also a Prisma Flex out there as well. Those are really the two main machines that we run in the hospital. Here at our hospital, we run the next stage. Prisma Flex, we'll kind of talk about that a little later on in the talk as well. So just briefly go over some of the things on the CRRT. Just remember, a little different than hemodialysis. Basically, the modality is going to be your difference. It's not our hemodialysis is done through osmosis and diffusion, whereas the blood and the dialysate never mix. The blood goes inside the tubing, the dialysate goes on the outside of the filter. And like I said, through osmosis and diffusion, that's how you are able to pull things off, put electrolytes back in, and so forth. Whereas the CRRT is more convection. The quicker we run the dialysate through the machine, the more it's going to clear. Now, we've often described this as a kinder, gentler dialysis. That being said, dialysis is dialysis. We're taking blood out, we're cleaning up, putting it back in. It's just some of the things that we're able to control on the CRRT versus hemodialysis that tend to make it a little more gentler on the body. We tend to run the CRRT on the more sicker patients, the ones that truly can't do dialysis unless we're maxed out on pressors and so forth. We'll bring the machine in. Just remember, this machine will do over 24 hours, what you can do in about 3 hours with hemodialysis. That also being said, if there is anything emergent such as high potassiums and so forth, this is not the machine you want to bring into the ICU initially right off the bat, because this will take a while to drop the potassium and so forth. So anything that's critical right off the bat, we need to try to get them on hemodialysis to begin with, correct the problem, and then get them off to this machine. On the flip side to that, if we are on pressors with this machine and it's a metabolic issue, metabolic acidosis or something like that, this machine is the machine you want. This machine will correct the acidosis. That will allow your pressors and so forth to work better with the individual at that point. Not all dialysis will drop pressures. You'll actually be surprised that your pressures will get better while the patient's on this machine as opposed to when they're off of it. Some of the indications that we're seeing with the next stage machine here lately, for a while now, we've used them in big burn situations. We know the amount of fluid that we're putting into a burn patient. So like I said, some of the indications that we're seeing this in use for is we're seeing it in the burn world that I'm in. What we're seeing with the larger burns is we've noticed a trend over the years that the amount of fluid we're putting them in, we sometimes put them in an acute kidney injury or an AKI, just for the sheer volume. What we will do is we'll preemptively start them on the CRRT. We will try to keep even with that fluid at that point. We will not pull too much off because that will kind of defeat the purpose of the fluid resuscitation. But we'll try to stay even at least somewhere into the resuscitation at that point. Kind of helps the kidneys, give them a break at that point, allow them to kick back in. Other indications that we're seeing with the CRRT is our sepsis protocol. When we have a high lactic acid level, this machine will do really well with these patients. Basically, you'll drag the blood through, it'll pull all this fibrogen and everything out of the blood system, at that point decreasing the lactic acid, so we can drop the lactic acid levels with this machine as well. Some of the other indications that we run in, that we're seeing is all fresh hearts, open hearts. We'll put them on for the first 24 hours, give that heart that break, the afterload and so forth. After 24 hours, we'll take them off at that point. So a lot of indications we're starting to see with the CRT, kind of things that are coming around the corner as far as uses with it. Now, when I talked earlier about the difference between CRT and hemodialysis, you got to remember, hemodialysis, more chronic type patient population. These are the patients that tend to run 3 times a week for 3 to 4 hours. CRT, remember, is a 24/7 type deal. Our ultimate goal is to get them over to hemodialysis if that's the case, if they need the hemodialysis. But once again, this is running 24/7 as opposed to that shorter spurt or that shorter time frame with the hemodialysis. Also with this machine, for those that don't know, this ultimately was designed for home use. I always joke with the nurses. I always say that if we could teach a renal family to take this home and use it, we can learn how to use it here in the hospital. So not a very hard machine to figure out at that point. Now, when I say we're hanging 20 liters, when I talked about the modality of the CRT, the convection, how fast we're pushing that dialysate through, just remember, whether it's 2 liters, 2.5 liters, 3 liters an hour, that will never get to the patient. So in reality, we're not giving that to the patient. Basically, it goes in pre-filter, it mixes with the blood, it goes out post-filter. That will go to a drainage system. So once again, all that's telling us is how fast we're going to push the dialysate through the machine will be an indication of how well we can clear everything. Now, the faster we push it through, the more it's going to mess with the blood pressure. Just kind of like hemodialysis, the more we take off, it's going to mess with the blood pressure. But remember, we have that option to slow that down. We have that ability to not push it through as fast. The other thing that messes with blood pressures is your fluid removal on these machines. Keep in mind, like I said, this machine will do over 24 hours, what the hemodialysis machine does over 3 hours. So if they're pulling off 3 to 4 liters of fluid in a 3 to 4 hour period of time, you know, we may be pulling off 2 liters over 24 hours. So we're not pulling the amount of fluid that hemodialysis machines pull off. We're not going to be dropping that blood pressure as much as they would do on hemodialysis. Your ultimate goal is not to go up on your pressors. Once again, when you start this machine, it's going to be, if I'm having an issue with blood pressures, maybe I'm pulling off too much that time, I can slow that rate down. I can slow the pull down on that patient. I can make it to where the blood pressures aren't going to drop like they normally would do on a hemodialysis machine. Along with the Prismasate, we also hang a bag of saline. We always flush when we start this machine up from the get-go. Basically, you prime the machine with normal saline before you'll actually start them on the CRT. It goes through a bunch of checks and balances this machine will do, so it takes a while from the minute you drop your cartridge in, put your saline on the machine to when you start priming it. It's about 15 to 20 minutes at a time, so you have that amount of time. The other thing about this machine is, although it doesn't have battery backup, it basically can recall some things. And there's this part in the machine when you're priming it, when it gets past all its checks, where you can actually unplug the machine, bring it into the room. You've got about 5-10 minutes to do this, but it will recall what it just did. It will drop the alarms back a little bit, it'll recheck a few, and then get you back to 23. But I always tell people when they go to set it, we don't necessarily have to set it up in the room. I know there's a lot of things going on when this machine comes into play. There's a lot of pumps in there, there's usually a ventilator, other things going on. So we don't necessarily have to set this machine up in the room. We can set it up outside. We can get through a certain point in testing. Once we get to that point, We can unplug the machine, we can wheel it in. Like I said, we have some time before it will erase everything that it just did. So it will basically go back to about 20 and then we'll eventually get to 23. So that being said, I will now show you Alright, with that being said, this is the cartridge that the CRRT, the next stage, uses. If anyone remembers the old machines when they first came out, it was more weight and balance type machine where you had fluids hanging down below and it's kind of based off the weight and balance. Everything now on this cartridge is done internally, so you have these chambers and so forth. Everything's done internally with this thing. Basically, it's a plug and play type system. You open the door, you drop your cartridge in, you close the door, you have a filter hanging on this side, and then when I talked about the saline, you have your saline hanging on the other side. This is all we need to actually start the machine. Your power button's on the back of the machine. You'll turn the machine on at this point. You'll get the faucet here to light up. That's your priming button. That's the button that you'll hit to start priming it. When I talked about difference between hemodialysis and CRRT, if you can look on the back side, this is your fluid, this is your blood line. So your fluid and your blood are actually going to meet pre-filter. It's going to go through the filter, and then post-filter, it's going to come back out. Blood will go back to the patient. The fluid will go to a drain, wherever you choose to drain it for. Whereas in hemodialysis, basically your blood would come in, your fluid would go in post-filter, it would come downstream, your blood goes in-stream through the filter, and like I said, through osmosis and diffusion, it's going to either go from less gradient to a higher gradient or a higher gradient to a lower gradient. But the CRRT is designed for convection. So pre-filter, they're going to mix together. Post-filter, they're going to come out. All right, so besides indications of it, the flip side of it would be complications. What kind of complications do we see with this machine? First and foremost, hypothermia. Anytime you're taking blood out of the system, you have a tendency to make that patient a little colder than they actually are. Big burns are real susceptible to this. They're already in a hypothermic state. Taking the blood out is not going to help them out. There is a warmer on this machine. When we go over the machine itself, I will kind of show you, but just remember that warmer is not for the patient themselves. It's just basically to get the prism state that I'll show you here in a minute to get to room temperature before it actually reaches the machine. So even though we say that there's a heater on here, it's not for the patient. It's going to be strictly for the dialysate itself. Other things that you run into with whether it's this type of dialysis or hemodialysis is electrolyte imbalance. You've got to pay really close you really got to pay attention to what their electrolytes are doing. Are they trending up? Are they trending down? Your potassiums and so forth. Like I say, not necessarily so much with this machine, but with the hemodialysis, the electrolyte exchange, electrolyte balance, and so forth moves a lot more as opposed to this machine, because this machine will do it a lot slower than your hemodialysis machine would be. But remember, if they're on this machine, it's probably good practice to at least get labs every 8 hours or so, just to kind of look at what is my potassium's doing, what's the bicarb doing, and so forth. So a couple things. The other thing with this machine is that we don't use fistulas or grafts with this machine. This machine can only be run through a double lumen dialysis catheter. There have been instances where we've had chronic patients that will need the CRRT. We will use their graft or their fistula, but that's only a temporary thing, with the understanding that the surgeon will be coming in at some point within a few hours to get us a double lumen dialysis catheter, because we as a bedside nurse, not being a dialysis nurse, cannot be responsible for the needles that are in the fistulas or grafts. So anytime this machine is run, it needs to be run through a double lumen dialysis catheter, as opposed to if they already had a pre-existing graft or fistula. With that also being said, with your double lumen dialysis catheters, infections are very high risk with these patients. So we're always pretty sterile, getting them on, getting them off, and so forth. We always mask and glove to take them on, take them off. Last thing you want to do is get some kind of a line infection to where we can no longer use that line. We'll have to switch it to a different site and so forth. Along with that line, just remember that that line is just like any other line. If we're not using it, we have to coagulate it or anticoagulate it. So whether it's heparin, I know we've kind of gotten away from our Gatraban. There are some times where we can't use any heparin at all. For example, if the patient's in HIT or something heparin-induced deal where we cannot give them heparin. So whatever you use to secure your lines, whether it's routine flushing or if it's heparin or so forth, make sure that you always have your line secured if it's not in use at that point. Because like I said, just like the infection and so forth, the last thing you want to do is lose that line. Now the machine itself, different parts to it. You have your base, which there are some times where we can't use any heparin at all. For example, if the patient's in HIT or something heparin-induced deal where we cannot give them heparin. So whatever you use to secure your lines, whether it's routine flushing or if it's heparin or so forth, make sure that you always have your line secured if it's not in use at that point. Because like I said, just like the infection and so forth, the last thing you want to do is lose that line. Now the machine itself, different parts to it. You have your base, which is your main part of your machine. You have your heater over on the side. Like I said, the heater is not for the patient, so if your patient's hypothermic, you've got to figure out another way to warm them up other than this little heater over here. Then you have the screen that will tell you exactly what the machine's doing. Along with that, you also need your cartridge setup. You need your dialysate. Now, the other big thing between hemodialysis and CRRT is with the hemodialysis, you have to bring in a water system and all. With the CRRT, the dialysate bags is the water system, it's the acid, it's the bicarb, all rolled into one bag. Now we will hang 4 bags on the back, which is about 20 liters of fluid. So a lot of fluids going in. All right, so through the magic of time lapse, we are now to the end of our time where we've primed the machine. It's actually gone through all the alarms. It's tested itself, basically what it's telling you now. It's ready to go. So anytime you see that 23, that means that we're good to go. Now, this at the point when I talked about it earlier, if you need to move the machine from outside the room to the room itself, you can unplug the machine, but you have to wait till it gets to 23 at this point. Once it gets to 23, like I said, we can unplug the machine, we can bring it into the room, we can plug it back in. It will jump back to about 21, it will retest itself, but you'll eventually get back to 23. So once you get to 23, what this machine is telling you that it's ready to go, it's tested itself and so forth. Just a few connections that we need to make before we get started. The first being that you need to take the filter out of the holder here. So Maddie's going to remove the plastic clips and she's going to put it up on the holder itself. So always make sure when you put it on the holder itself that you have the little pigtail outside because this will take the air out if you ever get air into the system at that point. Besides that, we also need to make connections from the bag. This is the time where you'll connect to the actual fluid line where it will be draining out at that point, and this is where you'll make connection to the patient. Now, when it says 23, the pump's still running, so if we have to make any adjustments on this before we connect to the patient, we always have to hit stop. So we hit stop. The pump has stopped running, so we can do any adjustments we need to make at this point. We can open up any of these valves. It won't suck air in or anything else. So like I said, here's your pigtail where you'll take air out. If you get any type of air into your machine, it will get trapped in the filter, come to the top. Your red ports and your blue ports are your connectors to the patient. You'll know when you put a double dialysis lumen catheter in, you have a red port and blue port. It's not saying yet you have an arterial line and a venous line, because it's basically one big venous line. What it's saying is what line's pulling and what line's pushing back. On the machine, not the patient itself. The red line is going to be the one pulling from the patient. The blue line on the machine is going to be the one pushing back to the patient. It doesn't matter on your CVL what you hook it up to, but ultimately, when you go to prep your double lumen dialysis catheter, whatever line pulls back better, that's where you want to connect your red line to at that point, and then your blue line. So when we start talking about access pressures and venous pressures, you got to remember it's on the machine itself. It's not on the patient's CVL. So if you look at the machine right now, when we talked about hemodialysis versus CRRT, right here, if you can see, the green is the fluid coming in, the red is your blood. This is where they mix pre-filter, they go post-filter, it will come back out the green, it will go to the yellow at that point, and then from the yellow it goes to the drain. We have the option on the CRRT to do hemodialysis on it, and all that would entail is you would take your green port right here where it's going pre-filter, disconnect and connect it post-filter. So in essence, just like hemodialysis, your fluids are going post-filter, your blood's going pre-filter. The blood goes inside the filter, your fluids go outside the filter, inside the canister. And once again, now your osmosis and diffusion rather than convection, which is what the machine's set up to be at that point. When we talk about different things, the big things you want to look at are what are our pressures doing on the machine. Before we do that, we have to kind of set up our machine. When I talked about convection and the faster we push it through, the more we're going to clear. Maddie will show you your top line is what actually controls how much dialysate we're pushing through the machine. It will go anywhere from, you start pushing it up, 0.5 to 2.5 or 3. Just remember, the more liters we push through an hour, the faster you're going to clear it, the more you're going to be messing with pressures and so forth at that point. So your green is always coincide with the dialysate, whether it's volume or whether it's how much we're pushing through the machine an hour. Now your yellow line, just think of that as your urine. That's the amount of fluid we're going to be pulling off an hour. I can tell you that we usually tend to, right off the bat, we'll either run it at 0 for a while to see how their body reacts. We will run it at a set rate of 100 or 200 an hour, or at some point we'll go into what they call a net fluid removal. And basically what we do, the bedside nurse will do, is she'll take into consideration how much fluid's going into the patient, how much are we giving to the patient at that point, and then that's what we'll remove every hour. So we will keep up with how much there's either going into them, or we'll actually go to a negative. We will set it above and beyond what's actually ordered for the patient. At that point, then you're getting a true fluid removal. Like I said, with hemodialysis, you can remove up to 3 to 4 liters in a couple-hour treatment. With this one, it runs better when we do it a lot slower. So over that 3 to 4 hours, it's going to take us about 24 hours on the machine to take off what hemodialysis only does in 3 to 4 hours. I can tell you nowadays, the doctor likes to set it more for a set rate. So whether it's 100, 200, 300. The machine also runs better when we keep an even film on it. We're not going up drastically or we're not going down drastically. The other thing to keep in the mind is if we start having issues with blood pressures, our first instinct should never be to go up the pressors. It should be, are we pulling off too much at this point? If we drop your fluid removal and the blood pressures get better, we know it's more fluid removal or fluid issue rather than a true cardiac issue. So your first instinct should always be, if our pressures are starting to tank, if we're starting to drop pressures, am I pulling off too much fluid at this point? Either talk to your nephrologist, talk to whoever's running the show, maybe drop it to 0 for a little while, see if that doesn't improve your pressures, see if it's just not like a metabolic type issue. At that point, then slowly start going back up on that. Now, besides your fluid removal, you also have the red number down there. That's how fast the blood's going through an hour. We tend to run 250, 300. Whereas on hemodialysis, they run it anywhere from 400 to 500 an hour. So we're pushing it a lot slower through a machine. So in regards, your machine's going to tend to clot off a lot quicker than it would on hemodialysis. Like I said, that's the times where we want to start using heparin, either pre-filter or other things. Maybe increase your blood flow to get it going a little quicker so it's not clotting off through the machine. Now, on the base itself, there's also a second screen. If you hit the little beaker button right there, hit it again. You know you're on the second screen when you see the word volume down at the bottom. Basically, all this screen is telling you is how much dialysate we have. We hang 4 5-liter bags, so we hang 20 liters of dialysate on this machine. Well, this is us telling the machine how much fluid we have. Now, the machine doesn't know that, hey, we're getting close to empty. That's up to us. So anytime we hang new bags, whether we set it for 15, 16, whatever we set it for, that's going to correlate with how much dialysate we have hanging on the machine itself. So besides the machine, once the machine's up and running, we have several numbers we want to look at. The first being your access pressure, which is up on the screen itself. Now, what the access pressure is telling me is how much pressure is it taking to get from this red line, which is hooked up to the patient, to the machine itself. So if you hit the machine on, it will tell you your normal pressures should be between a negative, 50 and 200, negative 200. Anytime our pressures start getting higher than negative 200, we know we're probably having we're having issues with the access itself. It's not with the machine. It's not with it clotting. It's more access related. One of your quickest fixes that you can do is you can hit stop the machine. You can take your blue port and your red port and just swap them at that point. Because if you think about it, every hour, if we're flushing this machine, that blue port's constantly being flushed. So that's what's going back to the patient. So that's going to be your cleaner port. So it's not uncommon for you to run it for a while. All of a sudden you start having high access pressures. For us just to stop it and swap the line just because you are starting to get a little clot or something built up on the red side of it. Once you swap it, you're going to start flushing the red side on the patient at that point. So you're going to every 4 to 6 hours, maybe swap those lines back and forth, just depending on your pressures. So access is the amount of pressure it takes for the blood get from the patient to the machine itself. You also have a venous pressure. The venous pressure is the amount of pressure it takes to get from the machine back to the patient. So anytime you have a low venous pressure or a higher venous pressure, once again, just think of it like your arterial line. You may have some kind of clot in it, or you could be sluggish at that point. So anytime we start getting access or venous, more line related as opposed to machine related. Now, when we start looking at machines, issues that we have with machines, that's where your last two numbers come into play. Your effluent pressure, which is your third one down, that is the amount of pressure it takes to get from the machine to the drain. So anytime we ever get a high effluent pressure, I always tell people the very first thing you should think of is, hey, did someone roll something on that line, or is someone standing on that line? That's usually the culprit of high effluent pressures. But once again, the amount of pressure it takes to get from the machine to the drain. The fourth one, and probably your most important one, is your balance chamber pressures. That's the amount of pressure it takes to get from the back of your filter, which is right back here, to the front of the filter up here. That's the true indication. Are we going to clog, or are we going to clot off? Now it says that the balance chamber should be less than 600. I can tell you once you start getting in the 500 range, your machine's going to clot off pretty quickly. You could try flushing it a little more, see if that works. But once again, on any time you have a septic patient, high lactic acid, you're throwing all that fibrinogen into the filter itself because you're dragging it through. Regardless of what we do, usually going to clog off about every 4 to 6 hours. But like I said, ultimately, that is the pressure you always want to keep your eye on. How much pressure is in this filter? How much is it taking it from the back of the filter to the front of the filter? So basically, like I said, in a nutshell, that's kind of the CRRT. There's not a lot to it. Like I said, our bedside nurses run it. They run it 24 hours a day. We try to keep it up for as long as possible. Your ultimate goal is to be able to get that patient to transition from this, if they need to continue with dialysis, to go to regular hemodialysis, because ultimately that machine will do a lot more than this machine will be. But if you just can't do it, if the pressures aren't allowing you to do it, this is a machine that you really want to bring in, because there's a lot of things you can manipulate that will help with your pressures, as opposed to just doing hemodialysis. Hemodialysis will drop it. Ultimately, your goal is not to go up with your pressors. It's to see, are we able to remove the fluids, or is this a metabolic issue to where if we can correct that, our pressors will work a lot better, to where then at that point you can come down with your pressors. But like I said earlier, if you start having pressure issues, you should never, your first inclination should never be, I'm going to go up with my pressors. It's always going to be, am I pulling too much fluid at this point? Another good way to tell if that's the case, every hour we flush saline through that machine, we flush about 100 an hour. If you notice, your pressures are going up every hour when I flush it through. Probably more of a fluid issue than it is a true mechanical issue. So at that point, I would be on the phone talking to the doctor, hey, are we pulling too much fluid? Do we need to back off on the fluid? As opposed to, hey, let me just increase my levo, or let me, go up on whatever pressor I'm running to kind of help out with this blood pressure, because that's not your goal. Your goal is to get the patient to run here, get them down off of pressors, get them down off of FiO2, things like that, decrease the workload, remove the fluids from around the lungs and so forth, to get them to transition to the next state, whether it's hemodialysis or if their kidneys recover on the AKA phase of it, or we can just transition them off at that point. So like I said, in a nutshell, this machine shouldn't be hard. It shouldn't be foreign to bedside nurses or anything. It's truly not a hard machine to run. What I always tell our nurses is, regardless of what happens, this is kind of the low man on the totem pole. So if your patient's starting to crash or do anything, you should just take the machine out of play. Just stop the machine, get the machine out of play, worry about your patient at that point, and then come back up and reset up or whatever your next step's going to be. Other than that, like I said, not a lot more to explain. There's a couple difference, and I don't know, Maddie, have you ever used a Prismaflex machine? So big difference that you've seen between the two machines?
Not in the way they actually run, just in the easiness of how to use it. It's a lot more simplistic to set up a Prismaflex, so just a newer generation.
And that's what we've heard is the Prismaflex is a lot more user friendly the way they have it now set up. This machine's not hard to set up. It's just that the rarity of this machine and how often we actually use it, as opposed to us relying on the dialysis machine or the dialysis nurses to come down and set up the machine. So we're kind of at their mercy. If it goes down the middle of the night, it could be 3 or 4 hours before it gets set back up. So everything we've done in the past 12 hours or however long we've been running kind of gotten wasted just because this machine goes down for 4 hours. So at some point, like I said, I really wish we could get to the point where we as the bedside nurses could set the machine up ourselves and run it. We would take more ownership over the machine. But ultimately, it's not a hard machine to run. Like I said, just a few things just to always keep in mind. Just always keep an eye on your balance chambers. What are our balance chambers doing? Are they starting to increase? You as a bedside nurse also, every hour we write down all the numbers so you can kind of graph it out, seeing, I started off at 200 and now we're up to 500 and we're towards the end of our shift. Probably a good chance it's going to go down before the shift ends. So just keep an eye on that. Just remember, anytime you have access pressures or venous pressure issues, it's more of an access related issue rather than a machine related issue. The machine tends to be more effluent or balance chambers. Once our balance chambers start rising or our effluent starts lowering, a pretty good indication your machine's going to clog off, depending on if we're doing it for sepsis or why we're actually running the machine. But like I said, in the burn world, we try to be preemptive on a lot of our patients, especially the larger burns that need the fluid. That it's really hard to tell how much insatiable blood fluid loss they're actually losing unless we actually physically go through and weigh sheets and stuff like that. So it's more of a game of what are our pressures doing? Are our pressures holding up to the machine as we're pulling off fluids or so forth? That's what we tend to look at more. Whereas you get more cardiac related, you can actually, look at more urine output versus loss and so forth. So other than that, not a lot more to the machine. Like I said, just remember there's two machines out there, next stage and the Prismaflex. So, whether it's at the modality is the same between the two. It's that the blood and the fluid aren't mixed, or they're mixing pre-filter, and the faster you actually pump it through, the more you're going to clear. But just keep in mind, the faster you push it through, you're also going to mess with blood pressures. So if you can slow the thing down, kind of go slow and low at first with this machine, and then kind of work your way up, your life's going to be better off at that point, as opposed to just kind of trying to hit them, balls to the wall right off the bat. We're going to pull a bunch of fluid. This machine's not the one to do it. That's more hemodialysis at that point. So other than that, any questions you can kind of get with Kumar Villachami on that. We can answer some. We'll be more than glad to answer questions via text messages or emails, however you guys get in contact with them. But that kind of wraps up our series on the CRRT. There are other series come. We've done one on wound vacs. I think we're going to do one in the near future on burn dressings and different types of dressings that we use here in the burn center. So there'll be other things coming down the pipeline. I can tell you that there have been instances where we use this on a pediatric population, but it's a different filter that we use for the pediatric population. It's a smaller filter. It's smaller tubing, so less of their blood volume's actually outside the system. That also being said, any time that we ever have to waste a cartridge, if we can't get the blood back to him before it goes down, there's usually about 200 mLs of blood outside the system that's actually in this system at any given time. Not necessarily a bad right off the bat, but once again, if you go through 3 or 4 setups in your 12-hour period of time and you're not getting the blood back to them, that could be a significant drop at the end of the shift. So just keep that in mind and just be preemptive with the machine. If you notice that the machine's starting to clog off, really the best thing you can do is get the blood back to the patient before you actually shut the machine down and get it off them. In emergent situations, just stop it, just disconnect and do what you have to do with the patient before you move on at that point. So like I said, any questions you guys may have out there, like I said, quick tutorial on how the machine gets set up and how we run it. Just remember, not only with this machine, we also will have 4 or 5 liter dialysis bags that will hang at the back of the machine itself. So back on the hooks back there is where you'll have your dialysis machine. The other big thing that nurses always worry about is what to set their volume for. Even if you know it takes your pharmacy a while to get the fluids up or get the dialysate up to you, once again, this number up here controls how fast it runs through. If you just drop the number down, get it to 0.2, and that will buy you enough time to get fluids up there. Just remember, once they get back up to bump it back up to whatever your dialysate was running before you turned it down at that point. So like I said, any questions or concerns, just relay them to Kumar. He should be able to get us questions. We can answer any questions. But like I said, there's going to be more in this series besides CRRT. Like I said, we'll talk about dressings and other things like that as well. I know we did one on the wound vac. Carver did one on the wound vac, so we will continue to bring these to you as long as you continue to watch. So,
But yeah, thank you so much, Chris. Thank you, Madeline. Appreciate you both. Thank you.
And